Hello, everybody. My name is Julia Burrows. I am with the American Society on Aging as a program coordinator. Welcome and thank you for joining us for today's National Alzheimer's and Dementia Resource Center webinars as part of their series. This is sponsored by the Administration for Community Living and hosted by the American Society on Aging. We will be getting started in just a moment. A few housekeeping notes. The slides for today's presentation are available under the tab on your screen labeled Resources. Under the tab labeled CE Application here, that is where you will find information on how to obtain CE credit for this event. You have 60 days to complete a continuing education application, and then it may take up to 30 days from the date of your application for us to process and issue your CE credit. If you are not logged in directly to this webinar, that is, if you're watching as part of a group and did not log in using an individual confirmation URL, then you will not be eligible for continuing education credit because we have no way to track your online attendance. If you would like to receive continuing education credit, please be sure to log in using your confirmation URL that you will receive after you register. If you have questions during today's presentation, you can send those to us at any time using the questions box, and we will save those for the last 10 to 15 minutes of today's program. So today, now I would like to go ahead and turn it over to Sari Schumann, Senior Research Public Health Analyst with the National Alzheimer's and Dementia Resource Center.
Hi, thank you so much everyone for attending today for our National Alzheimer's and Dementia Resource Center webinar, Promoting Brain Health Through Education, Insights from Community-Based Programs and Healthcare Systems. The National Alzheimer's and Dementia Resource Center webinar series is supported by the Administration for Community Living. Before we start, Erin Long of the Administration for Community Living will provide a brief welcome. Erin?
Hi everyone. I just want to take this time to thank you for taking the time out of your busy schedules to join us today to learn about promoting how ACL is promoting brain health through education in our grant programs. I want to thank Dr. Vijeth Iyengar, Lourdes Birba from AltaMed Health Services, Donna Barrett from Public Health, Summit County Public Health, for giving us their time and sharing their wisdom with us. And with that, I'll go back to you, Sari. Thanks again.
Thank you so much. So as you heard, today's presenters are Vijeth Iyengar, Donna Barrett, and Lourdes Birba. I will give their brief introductions, and then I will turn it over to Vijeth for the presentation. Dr. Vijeth Iyengar is a cognitive neuroscientist by training and currently serves as the Brain Health Lead and Technical Advisor to the Deputy Assistant Secretary for Aging at the Administration for Community Living. Dr. Iyengar serves as co-lead coordinator of the Older Adult Working Group for the Healthy People 2020-2030 initiative and is an ex officio member of the National Advisory Council on Aging at the National Institute on Aging. Donna Barrett is Program Manager of Senior Services for Summit County Public Health. Donna has been with Summit County Public Health Department since 2015, managing the health department's community health programs. She has more than 20 years of program development, implementation, and management experience with a focus on geriatric health and chronic disease. We also have with us today Lourdes Birba, a gerontologist and Vice President of Aging Services and Product Development at AltaMed Health Services. She is the operational co-lead of the ACL-funded Community-Based Alzheimer's Disease initiative in collaboration with AltaMed's Institute of Health Equity. Lourdes is responsible for an array of services, including a Medicare services team, and she also oversees a dedicated team that provides social work and housing navigation for AltaMed patients experiencing homelessness. Thank you all for being here today, and I will turn the presentation over to Vijeth Iyengar to get us started off.
Thank you, Sari. It's a real pleasure to join you all virtually today. I want to thank the National Alzheimer's and Dementia Resource Center webinar series for providing this opportunity. With the time that I have with you today, I'll be providing a very brief high-level overview of ACL's efforts to promote brain health in the community. So just to give you a brief roadmap as to what I'll be covering, I'll first talk about what is brain health, how do we define it, how it's been defined by different stakeholders in the community, what's the relationship between brain health and dementia, and then dive a little bit into ACL's brain health efforts, including our Brain Health You Can Make a Difference online resource, and grantee-led work to promote brain health in the community. So what is brain health? There are many definitions out there in both the academic literature and in the stakeholder community. It's an emerging topic of importance. So I thought I'd take a few minutes to define how brain health is used and how we operationally define it. So according to the National Institute on Aging, brain health refers to how well a person's brain functions across several areas that are important for our activities of daily living. So it touches on cognition. So how well do we think, learn, remember, and how can we use these capacities to carry out our daily functions? Movement. It touches on how well we can maintain and control our body movement. Emotion. How well does one process and respond to emotions? How are we evaluating and appraising our emotions to then dictate our actions? And then touch. So how well do we feel and respond to sensations of touch? So our ability and our brain's ability to help us achieve these four functions, it can be defined as one's overall brain health. The World Health Organization has a complementary definition of what brain health is. To quote, good brain health is a state in which every individual can realize their own abilities and optimize their cognitive, emotional, psychological, and behavioral functioning to cope with life situations. So the net takeaway is that brain health refers to one's ability or how well a person's brain functions to support one's daily life activities. Now, what's the relationship between brain health and dementia? Here we're referring to Alzheimer's disease and related dementias, and they can certainly impact a person's brain function and its role in supporting execution of daily life activities. There are several potential threats to brain health, including brain injuries, so traumatic brain injuries or head injuries, excessive alcohol use, smoking-related risks, and some medications and improper use of medicines via polypharmacy. And there are certain health conditions that can affect our brain health, including dementia, heart disease, stroke, diabetes, and inadequate sleep, and conditions that affect our sleep quality. So what do we have at ACL in terms of resources that communities, health systems, educators, and other advocates can use to then raise awareness and education of brain health in their communities? We have a wonderful resource called Brain Health You Can Make a Difference. It's an online resource filled with PowerPoint slides and handouts for healthcare professionals and educators that covering a range of topics including brain health basics, medicine age in your brain, brain injuries, and dementia. And it's designed in such a way with other federal partners in some cases where someone could go and take that material and be able to apply it and disseminate it in their own catchments and communities and other service delivery settings. It also includes webinars, briefs, and case studies providing perspectives from community-based organizations as to how they are taking up these materials to then boost awareness and education of brain health. ACL has historically, over the past many years, funded activities, services, programs, and supports that enable increases in education awareness of brain health in the community. From the years 2014 to 2020, ACL has supported brain health services or activities from 23 unique organizations spanning 15 different states nationwide. What are some of these services? Well, they include psychoeducational programs for family caregivers or persons living with dementia, educational series, either one-hour trainings covering basics of brain function, types of dementia, and living with dementia, and community presentations covering topics on healthy lifestyle choices, risk reduction, and signs of cognitive impairment. With that, I will close this high-level overview of ACL's brain health content and what brain health is. Feel free to reach out to me at that email address provided should you wish to learn more about our brain health efforts. Now it's with great pleasure to introduce the next speaker, Donna Barrett, who will provide a community-based perspective as to how she has used brain health resources to then apply it in her community setting. Donna?
Thank you, Vijay. Thank you, NARDC and ASA, for allowing us to share our project with the folks online. As Vijay said, my name is Donna Barrett. I'm a licensed social worker and a program manager of senior and adult services in Summit County, Ohio. I work for the Public Health Department. And just to share that our project is supported by a grant from the Department of Health and Human Services, Administration for Community Living, Administration on Aging. The views and opinions expressed in this PowerPoint presentation are those of the presenter and not necessarily of the presenter's organizations, including the U.S. Department of Health and Human Services and the Administration for Community Living, Administration on Aging. So let me give you a little overview about Summit County and Summit County Public Health. Summit County is comprised of 9 townships, 9 villages, and 13 cities. Akron is the county seat and houses about 37% of our county's population. Our total population in Summit County is approximately 542,000 folks, with seniors or older adults 65 and older accounting for about 11.2% of those folks having Alzheimer's disease. And we do a breakdown of the numbers. You can see from the slides that 1,619 of folks in our community, 65 to 74, are living with Alzheimer's disease. 4,446 folks, 75 to 84, are living with Alzheimer's disease, and 4,841 older adults 85 and older are living with Alzheimer's disease. And to just give you a pinpoint, Akron is near Cleveland, Ohio, and Akron is also the home of LeBron James, who is a national football player. So what does Alzheimer's disease and related dementia look like in Ohio and in Summit County? In Ohio, Alzheimer's disease is the 6th leading cause of death. Ohio was one of the top 20 states for Alzheimer's mortality in 2017, with 12% of those deaths being in Summit County. In 2019, the BRFS indicated that 11.6% of those folks aged 45 and older reported experiencing subjective cognitive decline, which is an increase in confusion and memory loss that is happening more or is getting worse. 83.4% of those with memory problems also have at least one other chronic condition, such as arthritis, asthma, COPD, cancer, cardiovascular disease, or diabetes. Ohio's adjusted Alzheimer's disease mortality rate is 34.9 per 100,000, and in Summit County it is higher at 36.7 per 100,000. Vascular and unspecified dementia mortality rates for Summit County is higher than that at 42.5 per 100,000. So here's a few maps of Summit County. The first map shows a population of our population 65 and older. And you'll see in the darker areas, those are where the highest percentages of people 65 and older lived in Summit County between 2015 and 2019. And those are actually in the outer rings, the suburban areas. And then you'll see some inter-ring zip code areas where we also have a higher percentage of folks 65 and older. If you look at the next map, these are our deaths, Alzheimer's and related dementia deaths between 2016, and again, you'll see higher percentages of deaths related to Alzheimer's disease in the outer suburban rings, where we have higher increases of people over the age of 65. So why did we choose to move towards implementing the brain health education, ACL's brain health education? Well, first of all, we looked at the results of our community health assessment and our community health assessment improvement plan. And what we notice is in our county that we do have a higher percentage of older adults, and that those older adults The numbers are getting higher. We also, as a senior and adult services program here at the health department, we developed strategic goals that are focused on Alzheimer's and chronic disease. And 4 out of 6 of the goals for the Community Health Improvement Plan include goals that are specific to dementia and chronic disease, which include promoting and providing culturally specific Alzheimer's disease and related dementia prevention, healthcare, and long-term planning education to improve quality of life and to reduce risk factors related to chronic disease among seniors. The Healthy Brain Initiative, state and local public health partnership to address the roadmap. We actually just became a site for the Health Brain Strategist, and so we will be moving towards implementing some of that work as well through the BOLD project. Stigma and Fear. I've been a social worker for 25 years, and a lot of my work has centered around working with the community and working with people, older families, older adults and their families, focused on addressing the needs of people with dementia. And what I've learned is that stigma is a hindrance for people to get screened, to go to their doctor and ask questions. And so I looked and I found a study that showed that stigma related to dementia and mild cognitive impairment can have a significant and negative impact on interpersonal relationships, interactions with health and healthcare communities, attitudes about service utilization, and participation in clinical research for people who may have Alzheimer's disease or related dementia. In this 2020 study, the question was asked, in your opinion, do you think there are negative associations, i.e. stigma, about people who have dementia in the country where you live? And more than 75% of the respondents said yes. 42% identified negative examples, 28% felt discounted or marginalized because of their diagnosis, 24% of the people lacked understanding of what to do when having a conversation with a person with dementia, and 24% of the folks felt that people needed to know how to be involved more. So what did we do? We here at Summit County Public Health, in partnership with VGES and ACL, we reached out and we are actually using the PowerPoint presentations from the ACL's Brain Health online resources. And we chose those because it was going to be easy for us to implement and to be able to get out into the community and begin doing this work. And so we chose that PowerPoint presentation, Brain Health Basics, and there was a 2-page handout that came with that, which we actually share in the community when we're out doing outreach events for older adults. And then we also chose Medicine, Age, and Your Brain, again using their PowerPoint presentation from ACL, the educational brochure in the handout to share with our community. We, in partnership with ACL, developed the pre and post screening questions for the 2 PowerPoint presentations, and we worked and developed a pool of questions that included 64 questions of multiple choice, true and false, and intended actions post-training. Included in this pre and post screening were demographics about the participants taking the classes, and demographics about professionals. We're able to actually use these pre and post questions screenings in 3 different ways. We can use them just for the Brain Health Basics presentation or the Medicine, You, and Your Brain presentation, and we can actually use them together to pre and post screen folks for both presentations. Who's our target population? We're a public health organization, and our goal is to really address the healthcare needs of all of Summit County. And so any person in Summit County who's a community resident is our target population. So we're actually going to reach out to as many non-traditional places where we can find people at an earlier age to provide this education. Caregivers, we're going to reach out to persons with dementia, providers through our geriatric workforce enhancement program, and through some national echoes to get the word out to healthcare professionals. And we also wanted to be able to address disparities in minority populations within our community. Summit County is a large resettlement agency for refugees, and in the next fiscal federal year, we are anticipating onboarding for a minimum of 480 new refugees, and in addition to 200 Afghanistan parolees who were just evacuated from Afghanistan. So how do we plan to implement this? Well, we've already started our implementation, and so we are doing outreach at senior centers and health fairs. We have reached out to caregiver support groups to be able to provide both educational PowerPoints to their support group participants. We are working with the faith community and working with ministries. Again, we're going to be working with the refugee serving agencies, our Akron Metropolitan Housing Authority, which has senior subsidized housing is a good place to go. And then we are going to offer these educational trainings both virtually and in person. So preliminary outcomes and some process improvement. Preliminary outcomes, we do have and have started tracking demographics from the educational series that we've started. We have some pre and post screenings, and our goal is to increase knowledge about the risk factors and the prevention mechanisms that people should implement to improve their brain functioning. Some process issues, always there's glitches in technology. What we find, it's better to collect data on pre and post screenings and demographics if you do that face-to-face than virtually. Virtually, we have a hard time getting people to complete both pre and post screenings, which can limit our data. So marketing, we are working with Knox Marketing, which is our marketing firm here at the Health Department, and we are in the process of developing a proposal to do a Facebook campaign and a landing page on our public health website focused on brain health, and both of those PowerPoint presentation. Our goal is to drive people from Facebook and social media to our webpage so that they can learn more about the brain health programs, and that they can request trainings from us to come out into their agencies to train members of their community, workforce, church, what have you. We plan to implement this marketing plan at the end of this year. We are also partnering with Lucas County Memory Lane, which is also an ACL-funded project for the APDI grant, and we partner with them on a lot of different projects, and we are in the process of developing the Train the Trainer for these ACL brain health PowerPoint presentations, so that we can train people in our communities so that they can train their own staff and other work groups or groups within their own agencies. And so we do that work with Lucas County, Scripps Gerontology, and Smile Minded SmartWorks, who is Summit County Public Health third-party evaluator for our project. We are always looking for sustainability for our programs, and we both fiscally, financially, and also it's much easier to sustain a program if you have buy-in from agency leadership, and they value the work that you're doing, so that their employees and or their community residents are receiving the education that they need to stay healthy. And we also, again, as I stated, we were selected as an HBI roadmap strategist organization, and we hope to be able to carry on some of this work through the BOLD initiative here at the Health Department, focused on some other aspects of the roadmap. Thank you. And next, I'd like to introduce Lourdes Birba.
Thank you. Good morning, everyone. Thank you for this opportunity to be with you today and to share with you some of the insights on our efforts around brain health at AltaMed Health Services. Delighted to be with you and hoping that our time together we can talk a little bit about our efforts as a federally qualified healthcare center. Our goal today is to share with you our approach to developing brain health materials for patients as well as for our physicians, healthcare providers, our implementation process of brain health education, at which time we are initiating, and the importance of developing obviously materials that are relevant, instructional, and help increase knowledge on the importance of brain health, and that's really throughout with providers as well as our patient base. A little bit about AltaMed Health Services Corporation. We were established in 1969. We were known as La Clínica Familiar del Barrio. It was a little local clinic where people actually gave donations in a big water jug to see a provider, and the lines went around blocks to have access for health care. In 1978, we became a designated federally qualified healthcare center, and we are now the largest FQHC in California. We serve approximately 328,000 patients annually. That translates to close to 900,000 visits per year. And we offer a wide range of medical, dental, and support services from birth to senior years. And you can see internal pediatrics, women's health, behavioral health. We have urgent care. We have our pharmacies. And if you are unfamiliar with FQHC, I very briefly will give you some of the highlights. It's a federal designation that is authorized by the Department of Health and Human Services through Health Resources and Services Administration, or HRSA. You may have heard those terms. FQHCs serve a medically underserved area and or a medically underserved population. They're governed by a board of directors of which 51% is comprised of patients. It's a not-for-profit, and as you can see, it delivers a wide array of primary care and support services. We currently have, well, for those out of the California area and don't know the landscape, it's, as you know, very broad state, very spread out. We are in, AltaMed has 57 locations within Los Angeles County and Orange County, which is the southern part of California. We have 11 PACE sites, so medical sites 39. You can see PACE sites. PACE stands for Program All-Inclusive Care for the Elderly. And when I address some of our efforts around our clinics, it excludes PACE since they are sort of like a mini health plan and self-contained, so they have their own service model. We have our own dental. We are co-located in many of the sites. We have pharmacy, and we have over 3,000 employees throughout both counties. Through our community-based Alzheimer's Disease initiative, which we call CADI, we are very grateful for ACO partnering with us in these efforts. And our goal has been, since we initiated, is really improve the quality of life for patients and that are living with dementia and increase our capability. And that, when I say increase capability, it is about identifying patients in a more robust way, raising awareness both with our employee base as well as our providers, making linkages on their behalf or helping them with them, and providing greater access and quality of care. We are identifying those that are also living alone that who may need additional support. We're identifying patients at risk with education, where we can provide educational opportunities, and we'll talk a little bit more about that in terms of identifying those patients. And of course, we're identifying caregivers and working with them as those that support our patients. And we also find that we have a number of caregivers who are also our patients, since we serve sometimes multi-generational families and or just family systems in general. So we find that some of our caregivers are also our patients. Our approach to brain health has been very much a multi-pronged approach. The CADI initiative is helping us really have a broader reach by incorporating some smaller but significant ways to improving our services. For example, some of what's under the grant is identifying patients at risk. We've identified patients living with dementia and living alone, and of course who the caregivers are. But some of those more robust opportunities have been using our technology and making improvements that help with identifying patients, and we'll talk a little bit, get a little more into detail, but we've really leveraged that to improve in some of these areas, support our providers with information and education specific to dementia, and it really has allowed a much broader and more frequent discussions at various levels of the organization with influencers, both on the clinical end and on the administration end. So what is it exactly that we're doing? If we go to the blue boxes, identifying patients living with dementia, providing support linkages, we have done that through data mining, ICD-10 codes, and using other criteria, vetting them through our electronic health record. We follow up with one-on-one calls for inquiry as to those that are living alone. Using criteria, we have, and using reports, we identify those that are at risk so that we can conduct our outreach and education. And we make inquiries as to the caregivers through phone calls, and they're not always readily available or readily identified in the electronic health record. That is something that's in process within the organization, and so we are having meetings around, there's a multitude of meetings where what's happening is this initiative and these efforts and these conversations are now taking hold at a broader scale. So one of the things we are doing is how do we identify and document some of these other people, such as caregivers, in our electronic health record through telehealth opportunities that we are all now providing. So why we're doing it is to increase awareness, certainly build capacity as I'm describing to you. Hopefully you will see how we're really leveraging this opportunity to do that. Obviously support our providers and frontline staff, and leverage all the resources and opportunities that have been provided, are being provided through the funding, and ultimately increase access and greater focus on our patients who are living with dementia. The at-risk patient, we have identified the at-risk patient, and I'll show you how we went about doing that. But in developing the materials, we reviewed materials from credible sources. We knew that we had to align educational content to a number of points, including the patient population that we serve and the delivery approach, which would be telephonic, given the numbers that we have, and also just because of the setup that we are all facing in the last year and a half. We reviewed sources from National Institute on Aging, Alzheimer's Association, certainly materials from ACL. We had done some previous work with GWEP, Geriatric Workforce Enhancement Program, and then other clinical sources to help with the content. Our audience, for the most part, is our patient base, and many monolingual or Spanish, the Spanish language is their language of choice. And we knew it would have to take a conversational approach because it was telephonic, and we would have to ensure we conveyed the message and yet be engaging and interactive and kind of meet the patient where they're at in terms of their health knowledge, literacy, and acceptance of the information. There, as was alluded to earlier, people are very receptive. Some have fears and will say, you know, I don't really want to know much about it, just give me the basics. And so we have to kind of meet the patient where they're at. It is a 45 to 1 hour presentation, and we cover things like why brain health matters, tips for healthy aging, what's age-related versus what may be abnormal, dementia and its risk factors, and how can a patient reduce risk. This is done through our health educator, and this is a snapshot of one of the presentations. Again, this is telephonic, but it was designed in a way that the health educator could really hold a conversation. So you can see on the left side, we've got tips for healthy aging, talk that through, interact with the patient. The green box is supplemental information that could come up or could be used depending on how the conversation goes. And then you can see that we've also asked questions so that we can engage the patient on the phone as to what they're doing, how are they doing, what could they be doing, when are they going to talk to their doctor? Is this a good idea? So remember, we also have access to their health records. So we can also use that information to engage them and ask some of these questions for them to think about, ask us, and or even for us to be able to say, you know, it might be a good idea to go see your physician. Can we help you make an appointment, kind of thing. So those resources and that thought process is embedded in the approach. The average patient we identified as a combination of Latinx age, those that are 55 and older, and one of the risk factors. And of course, if you look at the teal bubbles, you will see that these are chronic conditions, highly, could be chronic conditions, pervasive in some of our communities. So those cardiovascular risk factors are included, and then there are others. So they had the Latinx, the age, and one of the risk factors. We started pulling reports and using the criteria, and of course it's very broad, as you can see. So we've identified over 10,000 patients that meet this criteria. Now, we have randomly been moving over for the CADI purposes, about 325 patients that we have right now. We're constantly looking for, you know, some of these risk factors. And we have begun, as of about close to 3 months now, I believe, focusing on those with some family history. And why that? We thought, well, it would be a good place to start, given that patients probably have experience with and or exposure to the condition. They may have questions or concerns around it if they've been around it, and they likely would be willing to follow with their doctor's orders or have more inquiries of their doctors having had exposure to it. Really is just a matter of engaging them and seeing what their concerns, fears, or issues might be. We used reports using ICD-10 codes, and those were related to the chronic conditions that you saw. We asked for data ranges, if they were seen in the last year, and we used 8 ICD-10 codes combining the criteria that shared with you. And of course, we excluded PACE and anyone under 55. So the codes included, you know, stroke, diabetes, hypertension, cholesterol, etc. And we were able to extract a good number of people, patients, as part of our database. We also can get referrals from providers and other patient-facing staff. So we use Epic as our electronic health record. We have been able to put one of those enhancements has been dementia support services. So it makes it easy for a provider to identify someone and send it directly to our work queue that flags a patient. They can also use an in-basket and instant messaging and, of course, email. But these are all features within our electronic health records. Upon referral, the health educator reaches out to the patient and, explains the purpose of the call and conducts a brain health pretest comprised of 4 questions. It's a knowledge check. And we have 2 self-efficacy questions. The same is true for the post. We have also recently added a couple questions as part of that conversation. Again, it's very interactive. We try to make it very interactive, which is, from today, thank you for your time. What is the most important thing that you've learned today about brain health, and what can you do to reduce any risks of developing dementia? And some people are very forthright about what they think or what their thoughts are. So that's just something that we have, it's kind of feedback also as to the time we have spent with them. We then hand off to our USC partner, University of Southern California, as our evaluator for the brain health post test. And for those that are interested, we mail an education resource packet that we are happy to share. For the provider, we have gone through some fairly extensive work on really getting champions and identifying our physicians who are very much aligned with our work. We have a geriatrician who is someone, and my clinical co-lead is another physician, who are just absolute champions. And again, leveraging ACL funding, we were able to have these conversations on a much broader scale that have much broader impact, again, influencers at the clinical and administrative level. And our provider put a training, a grand rounds, a 1-hour presentation designed for our providers to learn about dementia identification. Aside from a geriatrician, he has in the past run dementia clinics for the VA. And so his concern is always, not all providers are comfortable with this patient, this kind of patient that's living with dementia, or even identifying. How do we use screening tools? How do we use information that's attained and go to the next level of workup? When does a neurologist get involved? So all of that was covered in the presentation. How to evaluate using history, screening tools, etc. And there's much more work being done around that. His presentation, just to give you a snapshot, like we're doing with the Atrisk, he used a case and then presented the mini cog and had a discussion around what he was seeing and what that would look like. And then you can see that some of it very clinically oriented, things to look for, things to check for, what would be next steps, etc. It was well attended. We had, I believe, 54, 55 providers attended and again, a lot of that discussion is ensuing, and he is available to consult to our providers should they have additional questions, making himself available. Some of our accomplishments then, as reviewed, we've been able to enhance our patient identification process. We have a robust database. We are working on our electronic health record referral enhancements. We've been able to also add flags or alerts for patients living with dementia as we come across them and identify them, something that was not there. We also flag and alert for caregivers who are our patients, because when they come in to see their provider, that provider needs to know that they could be under tremendous stresses being a caregiver. And of course, we've done the scripting and the messaging, the presentation, both to that risk as well as our providers. We've created resource packets and We more recently added a CADI internal webpage so that anyone in the company can go there and get resources and or get more information. Just at a glance, we've been looking for the last year, we served a total of, and served meaning actually linking them to services, 271 patients in the last year. We trained 51 professional staff. That's frontline people, back office, providers. We've had 54, and of course this is ongoing. This is an ongoing process. And for the patients at risk, we are looking at those 4 questions that where we increase knowledge, and this is for the those that reported these were true and false, and so it was really a measure of did we improve some of that. On the high blood pressure one, we had some thoughts around that. There's a lot of health education that happens at AltaMed around those chronic conditions, and so while there was not increased knowledge, it doesn't mean they didn't learn. It just meant they knew what was true at the pre was true at the post. On the increased self-efficacy, you can see this is all the strongly agree. If we go to the both strongly agree and agree, that percentage jumps up to 88% and 81% respectively. And you can also see that the content and the information shared has been easy to understand, and it was comprehensive. And it was either strongly agree or agree. So we're keeping the pulse of how we're doing, and we can course correct at any point. And of course, this is fairly newer, so we will have more data as time goes on. So in summary, when we look at opportunities and sustainability, which is really our goal, it really is to develop a dementia-capable healthcare system. I have shared with you some of what we have been doing around EHR enhancement. We are now, our next steps, is to, in 2022, we have efforts of integrating some of these processes in a focused clinic strategy that we're embarking on with different panels, specific patient population that will be tiered in that will be some of what we're discussing. We're also in the process of creating clinical guidelines and workflows, and we have an initiative on the Medicare health assessment, the annual wellness visit, of which cognitive impairment is screened for. We are initiating discussions on what we can provide next for providers, and of course, we have our own AltaMed, internal AltaMed University. We've had initial conversations around creating more training for our employee base. And, it's like our community is really not only the community externally, but we have a large internal employee and provider community, our patients, and the community at large. And we have many ways of getting our word out through town halls, social media, newsletters that goes out into the community. So those are all opportunities we're embracing as we work towards our journey of, working with internal people, clinicians, and as I mentioned earlier, which are now more identifying more champions that can carry the message of raising awareness on that being a dementia-capable healthcare system. So with that, I will turn it over to Sari.
Great, thank you so much, and thank you everyone for your excellent presentations. We're going to move to questions now. You can enter those through the question and answer chat pod on your webinar platform. One of the questions came in was asking about how are these kinds of programs funded. Take a look at the slide that we have here for a little bit of information on the funding that helped Lourdes and Donna do the brain health work that they just talked about. And you can get alerted for the next round of Alzheimer's Disease Programs Initiative funding opportunities. So that is the answer to the first question that I found on here. So we have a few questions coming in, so please continue to do that. One question that came up was about, you both mentioned diverse communities. Donna, you mentioned the refugee population. Lourdes, you mentioned some monolingual populations. Can you talk a little bit about efforts that you have made to adapt materials to be culturally competent, or any interpretations you've had to do of materials thus far? And Lourdes, we can start with you.
Thank you. Yes, so our population may be bilingual, as I mentioned, or monolingual, predominantly Spanish speaking. And of course, where we're located, we serve those communities, as well as some African American communities, which would and others, but it's primarily Latino population. We've really looked at all the information, as I mentioned, NIA, we looked at GWEB, we looked at ACL, and we know that we have to adapt to a certain educational attainment level, which is typically 5th to 6th grade, no more than that. We have people that we have to adapt to explain information that may be technical or maybe clinical in nature in a way that's understood. We need to converse with the patient, so we are able to do that by modifying that and really making inquiry as to, are they understanding? Is that clear? Is that something, what kinds of questions would they have for their provider, and or some cueing as to, you might want to talk to your doctor about X. And so we help with that and cue that, and if we find flags, we can also send information to their provider that would flag something for the next visit and or at the moment. So we take more complex information and synthesize it in a way that we think will, that we believe will help our patients understand.
Great, thank you. Donna, anything to add?
Sure. So we, as I spoke, we have a large refugee community here in Summit County, and there are a significant amount of agencies that work with that refugee population, from the International Institute to Asian Inc. Services. And so in our conversations specifically with Asian Inc. Services, we talked about partnering to make sure that the information that we presented is culturally competent and that people understand it. And we also talked about having interpreters available to help with those presentations so that they can be spoken to the participants in their language, their native language.
Great, thank you so much for that information.
Sorry, I would also add that for anything that's external, we have a whole communication and branding department. So anything that would go social media, anything that's external, is vetted through that department, again, for cultural competency and obviously language level. And we work very closely whenever we need that for any source of communication that's outside of the organization, oftentimes even internal, but we do have that resource also.
Great, thank you. All right. Another question that came in has to do with how we can talk about brain health and prevention techniques and things like that when the target population for much of the dementia education programs is older adults, and dementia is developing for many years prior to that. So kind of a long question. So I'm wondering if you can talk about any efforts you've seen or have done through your systems to teach a younger population, community members, about brain health more specifically than just to the older population.
So this is Donna. So our target population is our general community, and we want to target younger people. We recognize that other aspects of our APTI initiative grant is focused on the person with dementia and their caregiver, and so we want to target an audience who is much younger. Maybe it's that 45 and older population who's starting to see that subjective decline, and so being able to reach out to agencies, maybe even employers, to do lunch and learns and things like that with their staff, so that we can start talking about those risk factors and things that they can do to prevent brain diseases.
This is Vijay. Just to dovetail what Donna said, I think she's spot on. A lot of the content that ACL has curated, in some examples with the CDC and NIH, is taking a real lifespan / risk reduction approach. So being able to raise education awareness of the ways in which one could reduce their risks that could threaten their brain health, and in turn reduce potential prevalence or susceptibility to dementia. So I think that's the approach that a lot of folks have taken, and the way in terms of how ACL and other federal government agencies have crafted their material.
Yeah, on our end, on AltaMed's end, one of those efforts is obviously reaching the at-risk. They're just at risk. There's no evidence of anything other than what can you do and raising awareness. But we have another component in the organization, which is a whole health education department. And because you saw the chronic conditions that that's so pervasive, there are efforts around addressing those from a preventive side. Now, we don't directly address the younger population, but it doesn't preclude us from teaming up with health education to ensure that is embedded. We did that with some of the work through GWEP. We've done that through some additional work in the past, where we talked about brain health as a piece of those chronic conditions and some of the preventive aspects or cautions that should be taken. So for this intended purpose, it sounds more fragmented, but we do have a component of that, and we're able to partner with them at any point.
Great, thank you so much. So Donna, a question came in for you. Someone has mentioned that most counties in their state have not included dementia questions in their community health assessment at this point. Can you talk a little bit about how you were successful in getting those questions included in the health assessments for Summit County?
So we haven't included those questions yet. That's a goal of ours, is to include those questions. What we did was we looked at our county's aging population, and in partnership with the Alzheimer's Association locally, we did an Alzheimer's brief. And in that brief, we pulled out the data that showed what our population looked like in Summit County in regards to Alzheimer's and related dementias. And so there were specific demographics that we looked at. There were specific other indicators such as mortality rates, location of where people lived, disparities related by race, that we looked at to kind of guide what we're doing with this work.
Great, thank you so much. If any of the speakers have any final comments they'd like to make, we have about a minute left for that, so I will let you give any final comments if you have any.
So this is Donna. I just wanted to say we just started our trainings within the last couple of weeks, doing our presentations out in the community, and they have been very well received. People are interested. We're stressing the importance of people who are older getting and working with their physician to get, that annual cognitive screening so that they have baseline information about their cognitive health. And then we're emphasizing, how important it is to manage those risk factors and decrease the likelihood of, having a dementia-related diagnosis in the future. And so I would like to say it has been successful with the few folks that we have reached.
Great. Well, we all look
I
forward
would
to
just
hearing
summarize.
more.
I just wanted to say that really the opportunity to through the funding to really engage so many stakeholders in this process is really very exciting for those of us on the team, in terms of creating more conversation, more influence around on the clinical side as well as on the funding side and services for our patients. So it's not a project or an initiative. It really has taken a broader hold towards, again, our journey for greater capacity to serve the patient living with dementia at our clinic setting. So that's very exciting, and we look forward to 2022 to keep that dialogue going and embracing some of the changes that will be taking place.
Great. Thank you so much, everyone, for your participation today. We look forward to having you at our next webinar on November 16th, Innovative Approaches to Supporting Professional Caregivers of People Living with IDD and Dementia. Registration information is available on ASA's website. And that's all we have for today. Thank you, everyone, for attending.
Thank you. Have a great day.
Thank you.